Yeah, hi everybody. I'm Lisa Wagar. It's really nice to meet you. This is our only in-person visit, but I just wanted to say feel free to reach out to me if you have any questions. If you're interested in immunology more broadly, I'm always happy to chat. So my office is just in Hewitt Hall, so it's just across the street a little bit. Feel free to visit anytime. So my research interests are actually in human translational immunology, so hopefully a little bit of relevance for you as well. What we focus on in the lab is adaptive immune responses in people. We look at this mostly in the context of infectious diseases and vaccines because that's one of the few places where we know when somebody's been directly exposed to an antigen. So we have lots of cool tools in the lab to be able to look at that. We use organoid models. We're using all kinds of new sophisticated methods to track the adaptive immune response and understand why people respond in different ways to different vaccines. So if you have any interest in that, feel free to reach out as well. Okay, so today we're going to be talking about hypersensitivity, hypersensitivity broadly, and then the recorded lectures are going to be on autoimmunity, which is kind of a special case of hypersensitivity. So today, our focus is going to be on the main types of hypersensitivities that exist. And in particular, we're going to focus on immediate or allergic type responses today. We'll briefly cover some of the other types of hypersensitivities, but most of that is in the recorded lectures. We'll talk about some of the mechanisms of action that are behind the scenes that regulate these hypersensitivity responses, what you can expect to see clinically in people experiencing a hypersensitivity, what kinds of interventions and treatments that exist, and some new interesting treatments that are still in clinical trials and things like that. Okay, so what is hypersensitivity? Broadly speaking, it's an injurious or pathologic immune response. So our immune systems are really essential for protecting us from pathogens, managing wound healing, other essential functions in our bodies. And so at this point, you've probably talked about innate immune responses, which happen relatively quickly but are somewhat non-specific. And you've probably talked about adaptive immune responses, which take a little bit longer to develop but are exquisitely specific to the antigen. So now we're going to talk about both of these together and how they merge together in these special cases. We need our immune response to be able to respond robustly when we have an infection or a wound or something like that. But what happens when that goes beyond what we'd expect to resolve that infection? In some cases, you can have a hyperactive response. So there's this delicate balance in the immune system between under-response, which means you don't clear the pathogen that you've been infected with, or over-response and you get immunopathology. So all of this is delicately balanced. What types of things can trigger a hypersensitive response? So the initial trigger could be something foreign, could be a microbe, it could be some kind of non-infectious environmental antigen out there in the world. Often we don't know what it is, or it could be self. So we should be tolerant to our own self proteins and antigens, but in the special case when that doesn't happen, you can have an autoimmune disease. Has anybody experienced a hypersensitivity reaction? Anybody want to talk about it? Cats, yes. Cats and dogs, very common. Dander, especially. Poison ivy, poison oak, poison sumac. Has anybody had these before? I found out that I've definitely been exposed to poison sumac while making these slides. I've played in a field of this stuff and had no idea. So not everybody responds to every hypersensitivity. Some other really common ones, bee stings, venom, dust mites. So if you get sneezy when you're in a dusty environment, sometimes that's related to hypersensitivities. Peanut allergy is a very common food allergy. These come in lots of different flavors. So as I mentioned, we're going to focus mostly on what's called type 1 or allergic hypersensitivity today. The main take-home message is that it is dominated by an IgE response, which is a special type of isotype of antibody, and that can result in mast cell-mediated reactions to antigens. So what is the main thing that we see in allergic response? A rapid vascular leakage. And that leads to mucosal secretions, inflammation. We'll go through all of those different steps in a minute. The allergic disease itself is often referred to as atopy, and a patient who is experiencing a hypersensitive reaction is an atopic patient. So in most allergic reactions, such as some of the ones we just talked about, foods, pollen, house dust mites, these reactions are happening because a person has been sensitized to some innocuous antigen in our environment. So it's not actually protective to us to make these responses. In this case, that antigen is called an allergen. And what we end up doing is making IgE antibody responses against it. And then when you're exposed to that same allergen again, it triggers the IgE response and leads to IgE binding to mast cells and basophils, and functions we'll talk about in a second, in the affected tissue where the allergen is. And this can lead to ultimately an allergic reaction of varying degrees of intensity. So some really common ones are listed on the side here. Systemic anaphylaxis, obviously very much not good. And in allergic patients, common stimuli can be to certain drugs, to venoms like a snake bite or a bee sting, certain foods, or from serum. So as you can imagine, the route of entry also has an effect on what types of responses get made. In this case, this would be likely through intravenous exposure. And that can lead to edema, so swelling, fluid buildup, increased vascular permeability, which is of course associated with that, laryngeal edema, so that's swelling around the throat, which can lead to obviously issues with airway breathing, circulatory collapse or blood vessel issues, and ultimately death in some patients. We'll go through some other examples like the Wheeling flare reaction, where it has a specific set of steps that you can actually see. Seasonal allergies, basically, hay fever, pollens, grasses, trees, those kinds of things. Often that's based on exposure through the eye or nasal passages, mucosal response, essentially. Asthma is really important as a trigger for other responses as well. Lots of people have a specific response to pets, dust mites, pollens. This is obviously through inhalation as the route of entry. This can lead to specific airway effects. And then food allergies we'll get into in a little bit. Okay, so what are some of the mechanisms that are underlying these allergic responses? So I mentioned that IgE gets made. So if you recall from your previous adaptive immunity lectures, you should know that B cells can secrete antibodies. In this case, in an allergic response, those antibodies are of the IgE isotype. These IgE antibodies have a constant domain, shown here, and there are cells in our immune system that are capable of binding that constant domain. So here, what we're seeing is a basophil. You can tell because it's all granular here. And it has this receptor, Fc epsilon receptor 1. And that can bind the IgE isotype antibodies. And that ultimately leads to activation. So what you find is that this basophil can now provide surface and secreted factors that enhance the survival of the B cells and further enhance their production of IgE. So it's sort of a feed-forward activation of this response. Another major type that's an effector downstream of this is mast cells. So mast cells are filled with these granules, and when those cells get activated, they release what's inside the granules, and this can lead to a series of different effects, depending on the location and also what types of granules, what's inside of them, basically. So if we're talking about a gastrointestinal tract response, this can lead to fluid secretion, peristalsis, which has the predictable consequence of, unfortunately, diarrhea and vomiting. Very unpleasant. If these mast cells are secreting near the eyes, the nasal passages, and the airways, that can lead to swelling in the airway, mucus secretion, and ultimately this results in congestion, blockage of the airways. That can be, wheezing, all the way up to basically restriction of the airway. swelling, mucus secretion, itchy eyes, sneezing, all the basic stuff that you've probably thought about when you think about seasonal allergies too. And then if these cells are in blood vessel areas, that can lead to increased blood flow and permeability of the blood vessels themselves, and ultimately increased fluid in the tissues. So basically more flow, more effectors get brought to those tissues. It can even lead to hypotension and eventually anaphylactic shock. So what are the actual molecules that are mediating this effect? So I mentioned that there are lots of different effectors downstream of this. So mast cells can make a bunch of different things that get secreted when those cells get activated. That can be some examples of enzymes that might have effects on the tissue matrix, the extracellular matrix. They can be some toxic mediators, which are important under some circumstances, like responding to parasites, Th2 type response, things like histamine and heparin. So anticoagulants, smooth muscle contraction, vascular permeability. All of the cytokines that you're seeing here are very much Th2 type responses, so IL-4, IL-13, and IL-33 can all stimulate Th2 type CD4 T cells to respond. There's some other ones that can promote eosinophils, and also TNF, which is important for inflammation. So all of these pieces come together to produce the allergic response. Another important aspect is that other cells get recruited. So once these cells are activated, you see attraction of other immune mediators, which leads to an amplification of this response. Okay. So let's look at an example of an IgE-mediated inflammatory response. So in this person, they have a grass pollen allergy. And in this example, they're actually injected intradermally with this grass pollen. So this for them is their allergen. In the early phase of the response, so within 15 minutes, you will see something called a wheel and flare reaction. So that's this thing here. And what's happening in that area is that mast cells are basically rapidly secreting histamine and prostaglandins, and that's acting on the blood vessels in this area. And that's leading to vascular permeability and vasodilation. So you see immediate swelling right at the site where the injection happened. So that's what happens immediately. There are also things that happen later on. So it can be 6 hours, it could be days, and it happens only in some patients, about 50%, where you get additional inflammatory infiltration. So now you have additional cells like eosinophils and neutrophils and T cells that can come in. And you can see now this is a huge bump. And basically these cells are infiltrating. This response is NF-kappa B mediated, which you might remember as one of the central transcription factors that mediates immune cell responses. And this particular part of the response is actually glucocorticoid sensitive. So you can see there's an immediate response, and then there's this extended late phase reaction in some patients. Another common type of response is food allergy. I think it's really important that not just you guys, but actually everybody understands what the response to a food allergen actually looks like. You know, as a community, we should all understand this because it affects 32 million Americans. A lot of people have food allergies, and it's rapidly increasing, especially in the Western world. So it's increased by 50% between 1997 and 2011. And actually the incidence of peanut and tree nut allergies, which are some of the most common ones, have increased 3 times their previous rate in US kids. So there's basically this grouping called the Big 8. These are the most common allergies: soybeans, milk, tree nuts, that's things like almonds, shellfish, wheat, peanuts, fish, and eggs. So those are the most likely things to see an allergic response against. They cover vast majority of patients with food allergies. What's really unfortunate is that often it goes undiagnosed for a long time. So for example, about a quarter of people who are getting epinephrine administration. That's the treatment, the immediate treatment for a severe food allergy. When this happens in a school, often nobody knew that that kid had an allergy at all. So it's a surprise, and it can be obviously very challenging in the moment and very stressful. What we're also finding is that against these big eight, children are outgrowing allergies more slowly and it's less frequently than in previous decades. And many kids are still showing allergic responses beyond age 5. There's also adult diagnosed allergies. It happens all the time, 15% of people. So overall, basically 1 in 10 adults and 1 in 13 kids have a food allergy in the US. So how is food allergy actually diagnosed? One way is to basically treat individual spots on the patient's skin with culprit allergens. So they do a careful clinical history to ask, have you noticed allergic type responses against particular foods? Is there something we should focus on? And then there are these skin test type of tests here. So basically, has anybody had one of these? I've had them. Yeah. So it's not pleasant, I can tell you. They basically put little pricks on your skin with different allergens. So it's a very tiny amount of the allergen. And if you're going to have a response to that allergen, you get basically a spot. You'll see edema, you'll see some swelling, some redness. It can look different depending on skin color, of course. So this is the way that they can actually directly demonstrate that a particular allergen is your allergen, the thing that you're responding against. The route of administration, as I mentioned previously, is really important for determining what kind of symptoms are experienced by the patients. So in the intravenous case, these antigens, the allergens, are coming from the blood vessel, and this activates mast cells nearby and leads to widespread release of histamine all over the body potentially. So that's acting on blood vessels globally potentially. In the event of a subcutaneous, that could be something like a bee sting or other venom, you're really activating the cells in the local area. That's where you get that wheel and flare type reaction. Potentially you get some swelling at the specific area, basically. For inhalation, so this is now a mucosal route of administration, the bronchial smooth muscles of the lung can be involved. So that's allergic rhinitis, for example, mucus secretion, nasal irritation. In the lower airway, if it's something lower down, you can get smooth muscle contraction, increased mucus secretion as well. Ingestion, so this would be more like food allergies. Now you have allergen being taken up at the gut, intestinal smooth muscle in this case, and so that can lead to contraction of the intestinal smooth muscle, vomiting, diarrhea, fluid accumulation as well, and it can also disseminate. So I have a severe mushroom allergy. If I eat mushrooms, I get these terrible gastrointestinal symptoms, and I also get swelling in my face. So there's some oral ingestion as well. Treatments. So this is the thing that we should all know, really. The best treatment is avoidance, especially when it comes to food allergies. If you know what you have an allergy against and you can avoid it, that's the least risk. Obviously, there are situations where the allergen is just out in the world and you don't really have much control over it. So then we have to manage those symptoms. In the event of a severe reaction, people are administered epinephrine, or an EpiPen is the colloquial name for this. So this is what that looks like. And there's also specific instructions in the actual EpiPen itself. So if you are ever in the situation where you're the one who has to do this, the instructions are there. So don't panic, just follow the instructions. There are also, in less severe cases, you can give somebody antihistamines to try to reduce the response. Potentially oral steroids, though that's a little bit controversial still. An interesting new treatment is oral immunotherapy. So I'll go through a little bit of why we think that works and how it might work. So the reason why we're focusing on these immunotherapy type strategies is because there's this idea in allergy that the skin barrier is where allergies begin. So exposure through the skin seems to be detrimental. In the diet, allergies stay quiet. So I don't know who's heard of these types of studies, but we found that little kids who avoid a particular food early in life are actually more likely to develop an allergy to that food. So that's actually reversed in terms of the strategy in recent years. It used to be that that was the recommended strategy, is avoid peanuts, for example, in really little kids. Now we say peanuts should be in the diet as early as possible to reduce the risk of allergies. So there's this idea that the skin barrier, the hygiene hypothesis, and exposure through the allergen in different ways can result in different types of responses. Another way that we've seen treatment is through allergy shots. Has anybody had allergy shots? I have all the allergic responses. I've had allergy shots for dust mites. Basically, the idea there is that you're slowly being exposed to the antigen in manageable doses, and that's slowly escalated over time. And people think that that works by switching your IgE antibodies to IgG antibodies. So they no longer stimulate mast cells and basophils to make those degranulation responses. Okay, what about oral immunotherapy? This is the latest thing that's currently in trials. So the idea here is very similar. You gradually escalate the dose of a potential allergen through oral exposure. So basically, if a child is peanut allergic, you would start with an extremely low dose of peanut and actually feed it to them every day until they no longer show an allergic type response. And then when they've kind of tolerated that, you move up to the next dose. So there's lots of interesting studies going on with this. Basically, the problem is it takes a long time to do. So this can be years, where somebody has to eat a small amount of peanut every single day. Right? It also has potential for side effects, of course. You're giving somebody who's allergic their allergen. So there's the potential for anaphylaxis if the dose escalation is done too quickly. It can just be painful in general. They're still having that response, so at a lower level. So people don't like to do it. There's a high dropout rate. So it might be more feasible for people who have more than one allergy, where it's devastating to their lives to have to deal with this. So it might be more attractive in that particular situation where you have to tolerate them to multiple antigens together. Or maybe in the future you can add something that would basically escalate more quickly. So maybe you can add something like anti-IgE therapy that would reduce their allergic response, or reduce the Th2 type mediators to the response. So there's this really interesting trial called the Artemis trial. I'll just briefly go over it. Basically, most of the patients are peanut allergic patients, and so they can't tolerate basically any dose of peanut allergen. So they recruited these patients, they have placebo patients, of course, that don't get any treatment, and they get randomized. So it's a double-blind study. The investigators don't know what the patients are getting, and the patients don't know what they're getting either. And they're basically exposed to escalating amounts of peanut as part of their diet. So, for example, up to tolerating 1,000 milligrams, which is actually just 3 peanuts. But that's a huge difference in terms of quality of life if a kid can go to school and not worry about accidentally touching peanut butter on the table. Right? So this was wildly successful. They looked at what dose of their allergen could a patient tolerate. They found that the people who went through this escalating dose treatment, most of them could tolerate a 300 milligram dose, so it's about 1 peanut. 60 to 70% of them could tolerate 2 peanuts, and about half of them could tolerate 3 peanuts. So I think this has some interesting potential for the future. We'll have to see what happens in the next study. Okay, so let's talk about some other types of allergy as well. Allergic rhinitis. This is also a very common form of hypersensitivity. About 10% of the US population has allergic rhinitis. How do we know? Well, the evidence of sensitization and the clinical symptoms associated with it are basically to airborne allergens. So a lot of them are seasonal allergies. When a particular tree is blooming, their pollens are out in the world, that's when the patients experience the worst rhinitis. It might not seem super serious, but this does lead to a lot of missed work or school days. It can be a risk factor for asthma and other chronic conditions like chronic sinusitis. And so the common treatments for this are oral antihistamines, the usual stuff, saline rinses to try to get rid of the pollen so that it's not just stuck to you all the time, steroid sprays at the nasal mucosa specifically, and potentially allergy shots. So I also wanted to briefly introduce some of the other types of hypersensitivities beyond the allergic or immediate type. This particular nomenclature of type 1, 2, 3, and 4 is kind of a classical way of thinking about hypersensitivity, but I will say it's generally falling out of favor because a lot of the times a particular autoimmune disease or a particular hypersensitivity will show overlap between types. So you might see multiple components coming from these different types. However, it is very common on standardized tests to see this, so I still want to show it to you, and you should probably know it. Okay? So as we just talked about, the type 1 responses tend to be associated with this immediate response, mediated mostly by IgE antibodies. It's a soluble antigen either coming from the world, food, those types of things. And as we talked about, mast cells and basophils are the main mediators of those responses, at least in the early phase. We'll go through these other ones, but type 2 responses tend to be against cell or matrix proteins. They're IgG mediated or sometimes IgM mediated. There's type 3 responses, which are against a soluble antigen, but it is often from self. We'll talk about the non-self version today. And then there's the type 4, which is the T-cell mediated hypersensitivities. Okay, type 2 hypersensitivity. The recorded lectures have a bunch of examples from the autoimmune case, but for general understanding, basically cell surface proteins are targeted or ECM or extracellular matrix components. So what happens here is IgM or IgG antibodies against those types of proteins bind to the protein, and that leads to activation of other immune cells. So those antibodies, again, have a constant region that other immune cells can see, right? And so that recruits those cells, things like neutrophils and macrophages, cells that have FC receptors, constant region receptors, and that can lead to ultimately opsonization, which is an antigen coated with antibodies, and then phagocytosis, so that gets taken up by the immune cell. That can have a bunch of devastating effects depending on what the particular protein is that's targeted. There are type 3 hypersensitivities. Again, there will be other examples in the autoimmune context in the recorded lectures, but let's talk about a non-autoimmune example today. So today we're going to talk about the Arthus reaction. And basically what happens is that a locally injected antigen, for example, this can come from vaccination, such as tetanus toxoid, you get a tetanus vaccine, or diphtheria toxoid, diphtheria Tdap vaccine. In a rare number of patients, when this is injected, it actually makes local immune complexes, which is the characteristic of a type 3 hypersensitivity response. Immune complex where these antigens and antibodies all get bound up together into a group. And that leads to complement activation, remembering the complement system, hopefully. And then that leads to activation of other immune cells, basically. So mast cells get degranulation signals that leads to local inflammation at the injection site. So this Arthur's reaction is basically characterized as a local vasculitis that's associated with the deposition of these immune complexes and ultimately the activation of complement. So when that happens, typically it happens within a few hours after vaccination. So this is not just your regular little bump that you might get from your COVID vaccine or your flu shot. This is a little more serious than that. And it's recommended that the Advisory Committee on Immunization Practices, the ACIP, suggests that people who have this type of Arthur's reaction should probably not get the vaccine more frequently than every 10 years. So you don't get your Tdap booster more than every 10 years. Okay, let's look at another example of a type 3 immune complex mediated hypersensitivity. One of the earliest observed ones was actually against this thing called serum sickness. So in serum sickness, foreign proteins are injected, for example, as a treatment for diphtheria. You might get an antitoxin from another animal. We'll go over how they actually produce that and why that happens in a minute. But basically, when a foreign protein is injected, you actually get an antibody response to that foreign protein. And it develops over 7 to 10 days, and it generates immune complexes. When those complexes get made, they can unfortunately deposit in places that are problematic. So because it's like a clump of protein, it can get deposited in the small blood vessels. So anywhere where there are really small blood vessels, immune complexes can be a problem. It can lead to complement activation if there's some IgM in there. And ultimately, this can lead to vasculitis, nephritis, and arthritis. The good thing is, in the case of serum sickness, this is a transient effect. So once that foreign protein is gone from your body, the response comes back down again. So this was the first immune complex disease that was observed. Basically, it's systemic administration of a foreign protein. So I actually wrote a little info here that I pulled from a paper. So the term serum sickness was actually first introduced by von Pirquet and Schick. So those are two guys who published a book that was called something in German. Forgive me. Serum Krankheit in 1905. And the authors described this illness that developed in some patients after administration of horse serum that had been given as an antitoxin for the treatment of diphtheria and scarlet fever. So basically, we'll go over how that horse serum gets made, but you're injecting serum from an animal into a person. They noted that there was a delay between the administration of the horse serum and the development of the symptoms of the serum sickness, and that this delay was shorter if the horse serum was administered again. So very much like other allergic responses, if you're repeatedly exposed, the response comes sooner and sooner. So von Pirquet actually recognized that animal antiserum resulted in both protection against that infection, but it also resulted in sensitization, sometimes with serious or fatal consequences. And so that was basically an immune response that caused some disease. That was something we didn't really understand at the time. And so in 1906, he proposed the term allergy for this altered response that they saw and called the thing that caused it the allergen. So that's where that comes from. He recognized that sensitization to an allergen leads to an accelerated response on subsequent allergen administration, and that was analogous to differences between primary and subsequent smallpox vaccine responses. So when you're making a response to a vaccine, you want the response to happen more rapidly. That's the whole basis of immune memory. In an allergen response, you, of course, do not want that. And basically, this observation in 1908 led to his invention of the tuberculin skin test. So he was actually the one who figured out that if you inject just under the skin a small amount of tuberculosis antigen, you can tell whether somebody has been previously exposed to it or not. Okay, so how does this play out in modern life? Well, to my surprise, while I was developing this lecture, I learned all about how they make antivenoms, and it's kind of brutal. So antivenom is also known as antivenin, venom antiserum, antivenom immunoglobulin. These are all the same things. But basically, we still make this in very much the same way as we used to make it almost 100 years ago. So antivenom production starts by collecting venom samples from the venomous animal. So let's talk about snake venom as our example. We've got a picture here of a coral snake. They basically collect snakes out in the wild and they keep them and then they milk them. So basically they make the snake bite a membrane and collect the venom that's secreted. You need quite a bit of it to be able to do these types of things. And then once we have a sufficient amount of venom, they pool this from multiple snakes to make a reference venom, which is now, in our case, the immunogen. They then take that venom and they actually repeatedly inject it into an animal, usually subcutaneously. Usually this is done in horses or sheep. And they do this in the presence of adjuvants, which will amplify the immune response to that venom. And basically the whole goal of this is to stimulate an antibody response in the animal that's treated with the venom. And ultimately what you want is an anti-venom antibody response, anti-venom IgG. Once this animal has been repeatedly exposed to the venom, they collect blood from the animal and then isolate plasma from it. So there's a whole manufacturing process that happens after that, including purification, isolation, as best as we can, and concentration of the antibodies. But ultimately what that means is that the treatment for a snake bite, if it's venomous snake, is horse serum that has these anti-venom IgGs in it. And so one example I've just listed here is antivenin, and they can have that classic type 3 hypersensitivity response. So patients that are sensitive to this coral snake antivenin or to horse serum might get an anaphylactic response to it. So if you are interested in this, I thought this was super interesting. If this is an area you're interested in, there's a really great SciShow episode on it, so I suggest you look it up if you're interested. Okay, and then the last type of hypersensitivity that we're going to talk about today is the T-cell mediated hypersensitivity. So there are plenty of examples of this in autoimmunity. There are lots of examples that we talk about in the recorded lectures, but broadly speaking, type 4 hypersensitivity can be a delayed type response. So that can be against particular proteins like insect venoms, mycobacterial proteins, and that can lead to local skin swelling, cell infiltration. T cells tend to join the response a little bit later. Or we can have contact site hypersensitivities. So these are haptens, which we'll talk about in 1 second, or particularly metal ions like nickel. So if anybody has a nickel allergy, it's a contact hypersensitivity reaction. Some other examples we'll talk about next time. Okay, so what does the delayed type hypersensitivity response look like? So let's take the example of an insect bite, where the antigen is injected subcutaneously at the skin tissue, and then it's processed by local antigen-presenting cells, right? So our skin is filled with antigen-presenting cells at the top layer as well as lower. And so when these cells take it up, they stimulate a Th1 effector response. So here's your Th1 T cell getting activated, and that leads to secretion of those Th1 T cells of cytokines and chemokines, which can act directly on the local vascular endothelium. And when that endothelium gets activated, it recruits additional immune cells to the site. So once again, it's going to result in a visible lesion, swelling, redness, the classic signs of inflammation. The types of responses that these T cells make when they get activated can vary, and they come in lots of different flavors. But broadly speaking, these Th1 T cells are going to produce some chemokines, which I believe you talked about already, that can recruit other immune cells like macrophages to basically the site where the antigen is present. They can stimulate interferon gamma production, which leads to effects on the vascular endothelium. And it can activate more macrophages to come in and other inflammatory responses to develop. They can produce TNF alpha and lymphotoxin LT, which can cause local tissue destruction, right? So this can directly have an effect on the local cells. And they can also make IL-3 and GM-CSF. So these can stimulate monocyte production by the bone marrow, and so ultimately you're making even more immune cells that can be drawn to the site. So what does a delayed type hypersensitivity reaction look like? In this case, we're looking at a contact sensitizing agent. So for example, poison ivy has such a protein. And basically, when this contact sensitizing agent penetrates the skin, it can bind to self-proteins. And those are called then haptens. So this is a covalent linkage between some protein that's been picked up and a self-protein. And this alters the structure and makes that protein now quite immunogenic. These cells these haptens are being taken up by Langerhans cells, in this case in the skin. So these are skin resident dendritic cells. Those cells get activated and they stimulate Th1 T cell responses, which can secrete interferon gamma and some other cytokines like we just talked about. It can also activate other cells in the area, like keratinocytes, to make chemokines and cytokines as well. And ultimately, when all of this comes together, what you get is major inflammation at the site. So, I mean, these are some pretty extreme versions. It does not have to look this extreme to be a contact hypersensitivity response. But these are just some examples. Maybe here are some less intense ones that you might see. So this is contact dermatitis. This is very common against, for example, nickel allergies. About a fifth of the population has nickel allergy responses. 85% of people have response to poison ivy to some level of contact dermatitis. And so some of the common symptoms are redness or other color changes in the skin, looks irritated. It can be very itchy because of all of those inflammatory mediators. It can be swollen. There might be bumps or blisters, or it can be flat. It can be, you can actually feel the temperature, right? That's a classic sign of inflammation as well, as it feels hot. Okay, so I wanted to wrap up with potential treatments, basically. So drugs to treat allergy are largely palliative. There's not a lot of preventive other than the oral immunotherapy that we talked about and the allergy shots that we talked about. Largely, this is if you are exposed to your allergen, what do you do? The best we can do right now is to try to counteract those symptoms and the inflammation associated with it. So in clinical use, we have, affecting the actual mediators of the response, the chronic inflammation, the Th2 allergic response, or the IgE antibodies themselves that are binding. And so you can imagine these work in different ways, including just inhibiting the specific effects of those effector molecules, prevent their synthesis in the first place, just generally reduce inflammation, inhibit Th2 responses with regulatory T cells or other suppressive immune cells, or directly prevent IgE from binding their mast cells and basophils. There's lots of different ways that we can do this. There's lots of over-the-counter and prescribed drugs to do this. But I would say, for the most part, the best thing that we can do is avoid. So, yes, we have these as a counteract to these potential issues, but the best thing for allergic patients is to try to avoid. So I wanted to put a couple of examples at the end of the lecture so that we could chat about it. Feel free to just think through it with me, or if you just want to hear my logic through it, that's also okay. But let's go through an example. So there's this 3-year-old toddler who's rushed to the emergency department after consuming a peanut butter cracker at a daycare. The daycare support staff know that the patient has a severe allergy to peanut butter, and he was accidentally offered the crackers. Unfortunately, this happens a lot. Patient's in acute distress, definitely some blood pressure issues, some respiratory issues, and some heart rate issues. So upon examination, there's an audible inspiratory stridor. So basically his breathing sounds struggling. Chest is covered in a rash. They try to intubate the patient, but this fails because of laryngeal edema. So there's a lot of swelling around the neck and airway. So what kind of mechanism is probably responsible for this? So is it complement production? Is it release of cytokine IL-4? Is it antigen-antibody complexes, cytokine IL-2 secretion, or IgE-mediated mast cells? Mast cells? Mast cells? Yes? Good. So how do we know? So the question tells you the patient has a severe allergy to peanut butter, right? They ingested their allergen. Food allergies, most common immediate allergic response. That's what should tell you that it's IgE-mediated mast cell degranulation. Other signs are definitely, the blood pressure issues, respiratory issues, heart rate issues, but also very common is rash and edema, right? Those are classic signs of immediate allergy response. Good. Okay, let's do another one. So a 10-year-old boy presents to the emergency department with sudden shortness of breath. He was playing in the school garden and suddenly started to complain of abdominal pain. He then vomited a few times, and an hour later in the hospital, he slowly developed a rash on his chest, arms, and legs. His breathing became faster with audible wheezing, and on physical examination, he's got all of these vital signs. The rash is on his right arm, and it looks like this. Does this look familiar? After being administered appropriate treatment, the boy improved significantly and he's able to breathe comfortably. So which of the following is the best marker that could be measured in the serum of this boy to help establish a definitive diagnosis? So I don't expect you to know this offhand, but this is the type of thing that you should be thinking about in terms of the mediators that are involved and maybe the order that things are happening. Any thoughts from anybody? Great idea. There's a problem which I'll tell you about in a second. Okay, so I think you're all on the right track. So he's got sudden shortness of breath, abdominal pain, vomiting, and then wheezing and rash. So these are all classic allergy signs, right? Basically, almost all of these are related to allergy except serotonin. So you're on the right track. These are all involved in the allergic mediator response. There's a couple of hints that help figure out what should we do? What kinds of detection methods do we have? Again, this is not something you should just know. This is something that I also had to look up. So we're measuring later, right? So we're not measuring the immediate response. Remember, histamine and things like that happen within 15 minutes most of the time. So we're already past that. Whatever happened is already happened. We can't measure it. And the other hint is that they're asking us to measure in serum. So there's only particular places in the body where certain things can be measured. So prostaglandin D2, yes, it's an inflammatory mediator. However, it's very hard to detect and it's rapidly cleared. Histamine can be detected quite well, but it has to be detected immediately. Otherwise, it's already gone. So that one's no good. That's out. Leukotrienes are actually traditionally measured in urine, so that would be the best place to measure. Tryptase is also one of the effector molecules, and it still works 30 minutes to 120 minutes after the onset of the allergic response, and it's actually also pretty specific to the allergic response. That would be a good choice. If you want to know more about these lab tests, I've put a link at the bottom, which you can all access. UpToDate is a great resource to go look at these types of things. It lists them all out and what kinds of tests are available. So that's it for me. I just wanted to highlight that these are the resources that I used today, including some Step 1 USMLE questions that I modified a little bit for you guys. And in particular, I wanted to thank Dr. Milton Greenberg, Dr. Aisha Ahmed, and Dr. Kari Nadeau, who all provided me with their slides and their clinical expertise on allergy and treatments. Without them, I would not have known as much as I did about these types of oral immunotherapies, which they shared their unpublished data with me. So it's very good. And if you have any additional questions, I'm happy to answer them with you. Yeah. I think it's difficult for us to know because the major research focus has definitely been on childhood allergy. I also know people who have developed allergies later in life. I think it's often mysterious, but I might imagine that in some cases there's some unknown trigger that we don't know about that led to that response turning to an IgE antibody response as opposed to some other isotype. So IgE is the major allergy-specific response. It's also important for things like parasites and things like that. But in this aberrant response, IgE is the one that's mediating the effect. So there must be some other trigger that eventually led to that response becoming IgE mediated. Yeah. You can imagine the opposite can happen too, right? So in childhood allergy, the child might have an IgE allergic response, and something happens at some point that leads to that becoming an IgG response. And so it's no longer allergic mediated. You can also develop suppressor cells that might reduce their response to some degree too. Other questions? On the allergy side, I'm not sure. But on the autoimmune hypersensitivity side, there's definitely a genetic component. So I would imagine that there could also be some genetic components involved in allergic type hypersensitivity as well.